Test. Test.
Hello everybody, and thank you for joining us today for our special 4-part webinar series on managing hypertension and diabetes patients by mastering health IT. Our presenters are Bruce Mackey and Dr. Gregory Macris, and my name is Leslie Kiesel. Before we get started, I have a few housekeeping details to cover. We're going to keep the phone lines on mute, but if you have a question, please put it in the questions box. If we're unable to respond during the presentation, we'll answer all questions within 1 to 2 business days via email. We'll also be posting a video and a PDF of today's presentation on mceda.org. For those of you that don't know, the mceda program is largely grant-funded and run by Altarum Institute. Altarum is a nonprofit with nearly 70 years of experience researching, developing, and implementing solutions that serve the public good by solving complex systems problems to improve human health. Our staff members are leaders in identifying, understanding, and solving critical systems issues that impact health and healthcare. From designing and developing health information technology systems to working with healthcare providers to foster clinical quality improvements, Altarum is widely acknowledged by the federal government, the state of Michigan, and the private sector as a valued partner. We currently have 400 employees across the country. Housed within Altarum, we are mceda, the Michigan Center for Effective IT Adoption. Originally born out of the HITECH Act, mceda is Michigan's regional extension center, and we're tasked with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted over 5,700 providers across the state of Michigan, impacting 1.6 million patients annually. And 1 out of 4 Michigan providers who have been paid for meaningful use is an mceda client. Our services are highly subsidized for qualified providers. Paired with our fee-for-service packages, our services include meaningful use support, and that includes any stage in any year, security risk assessments, targeted process optimization, which is an adapted version of lean principles, and we apply it to any clinical or operational practice improvement initiative you might have in your office. So no matter what you need help with in terms of improvement, we can help. Finally, we have attestation and audit preparation assistance for those in need of one-on-one assistance before attestation or after an audit letter is received. In today's presentation, we'll take a moment to briefly discuss the health problems we're focused on today, hypertension and diabetes. From there, Bruce and Dr. Macris will discuss the various ways you can leverage your health IT to identify these patient populations. Topics today include the chronic care model and team-based care, structured versus unstructured data, clinical decision support, and ways you can use existing information already stored in your EHR to identify undiagnosed hypertensive and diabetic patients. In addition to the information in this educational series, Bruce and Dr. Macris have developed a custom toolkit to guide your office with the recommendations in this webinar. With that, I'll turn it over to Bruce to get started.
Thanks, Leslie. As she just mentioned, we'll start off by briefly discussing the pervasive chronic conditions we're focused on today, hypertension and diabetes. No one can argue against heart disease and stroke being incredibly serious problems. They are currently the 1st and 4th leading causes of death in the U.S., with over 2 million heart attacks and strokes happening each year in our country. 29.1 million, or 9.3% of the population, have diabetes. The stats in our state are even worse, with an estimated 10% of Michigan adults diagnosed with diabetes. And an additional 250,000 Michigan residents are believed to be undiagnosed. As if that wasn't bad enough, the national and state numbers around hypertension are even worse, with approximately 70 million, or 1 out of 3 American adults affected by high blood pressure. Roughly 16% of Michigan's adult population does not have their hypertension under control. With disturbing figures like these, it's no wonder we continually see over 2 million heart attacks and strokes in our country each year. The strategies and tools we're discussing today can help to lower these alarming numbers. So what's being done to battle hypertension and diabetes in our country? The past several years have seen a steady shift to a new paradigm called the chronic care model, which identifies the essential elements of a healthcare system that encourage high-quality chronic disease care. Organizations must focus on these 6 areas as well as develop productive interactions between patients who take an active part in their care and providers who have the necessary resources and expertise. Incorporating this model leads to healthier patients, more satisfied providers, and cost savings. And leveraging your health IT will play an important role in successfully implementing this model of care, particularly when it comes to fostering these productive interactions between the informed, activated patient and the prepared, proactive practice team. Let's talk for a moment about the practice team. With the many moving parts of a clinical setting, the most effective way to manage chronic conditions is through implementing a model of team-based care that includes the patient's primary care provider, and other professionals such as practice support staff, nurses, pharmacists, dietitians, social workers, and community health workers. Team members provide process support and share responsibilities of patient care to complement the activities of the primary care provider. These responsibilities may include medication management, patient follow-up, and adherence and self-management support. Team-based care has been in practice for some time now and is currently the norm at some level in most organizations, but in the effective management of hypertension and diabetes, it's critical. Why does team-based care work, especially with chronic conditions like hypertension and diabetes? Team members work together by providing support and sharing responsibility for disease management. Many primary care patient visits are for elevated blood pressure, but patients typically have multiple health concerns. With competing health priorities and short 15-minute visits, high blood pressure is often rarely or minimally addressed. Also, given the focus on evidence-based guidelines, clinicians may tend to tell the patient what to do rather than asking them what they can or are willing to do, especially in that 15-minute visit. Health goals that are instead selected and planned by the patient have been shown to be very successful in helping to manage chronic conditions. In contrast, those selected by clinicians telling patients what they should work on have not been as effective. With many facets involved in managing chronic conditions, it's clear that it takes a multidisciplinary team to get the job done, a team that includes an engaged patient as one of many vital team members. With the importance of team-based care in mind, we'd like to introduce you to the model at the heart of this educational series, something we're calling the Health IT Patient Management Model. In a nutshell, it is a PDSA, or Plan, Do, Study, Act cycle that leverages health IT to identify, engage, monitor, analyze, and improve the health of your diabetic and hypertensive patients. The rest of today's presentation focuses on just one of these functional areas, patient identification. Additional sessions focus on ways you can leverage your health IT to engage and monitor, as well as analyze and improve the health of your patients. With that, let's discuss the various ways you can leverage your health IT to identify hypertensive and diabetic patients. Before we discuss health IT, however, we need to take a step back and acknowledge that improving patient outcomes relies first and foremost on accurate data collection. The old adage, garbage in, garbage out, comes to mind here. Teams cannot perform well if the data they're reacting to is inaccurate. Blood pressure is the most common and one of the most important clinical measurements performed in healthcare. Clinical staff perform the measurement of blood pressure multiple times every day, yet the American Heart Association reports that blood pressure readings are one of the most inaccurately performed measurements in clinical medicine. Most undiagnosed individuals with hypertension regularly use healthcare services. However, the variability in office-based BP measurement often prevents these individuals from being properly diagnosed and treated, in part because physicians have concerns about the reliability and accuracy of these readings. To effectively battle hypertension, teams need to be able to rely on blood pressure readings. To ensure this, take the time to hold an in-service to retrain your clinical staff in proper techniques for accurate blood pressure measurement. Full details on blood pressure measurement are available in the tool on our website, but some highlights are the patient should be sitting in a quiet room for at least 5 minutes with their back supported and their feet on the floor. You want to make sure the cuff is the proper size and is placed correctly with the arm supported and at heart level. Consider checking both arms at least once to ensure the results are equal. And record the results and all pertinent information in the record as structured data. Data that resides in a fixed field within a record or file is called structured data. Structured data fields are designed to capture discrete data for later use or retrieval, and they are a principal differentiator between an EHR and a paper record. Within an EHR, nearly every data point has a specific data field designed to hold that information. If those specific data fields are not consistently used, patient care can be negatively affected, and teams cannot easily trend, report, and act on results. For example, a medical assistant records a blood pressure in the appropriate vital signs data field. The provider later decides something was wrong with it and repeats it. He types or dictates the new corrected BP into the free text data field with the rest of the progress note. The initial incorrect BP is now the only one that counts because it is the one people will see when they pull reports and trend BPs. There are inherent challenges, however, with consistently using structured data fields. Depending on your technology, some structured data fields are clumsy and time-consuming to complete, either as a fault of the template used or of the EHR as a whole. If this is the case in your organization, don't simply accept a substandard product that wastes valuable time, or worse, causes team members to record data in alternative places where it can't be properly used. Work with your department, institute, or vendor to create practical solutions. Likewise, with lab results, scanning paper results into the EHR affords none of the benefits of discrete data capture, like graphing, trending, and recall, and though possible, manually inputting the results into the correct fields is a time-consuming, arduous task that is unlikely to be completed. Work with your vendor to install or create a lab interface where results are received electronically from the lab and populated directly into the appropriate structured data fields within the patient's chart. Lab interfaces are generally already available for large labs such as Quest, and for a cost, interfaces can be created for an institution or even an in-house lab. We just touched on strategies to capture and record patient data in your own office, but to get a complete picture of the patient, you also need to know what other healthcare providers know. Interoperability, or the electronic sharing of information between health IT systems, is a vital component needed to identify your hypertensive and diabetic patients. Your certified EHR has two means to do this, using the embedded direct or peer-to-peer technology, or by tapping into the network of Michigan's Health Information Exchange. Each certified EHR comes equipped with the ability to exchange information with other EHRs using technology or a protocol called Direct. Direct is little more than just secure email exchange between EHR systems. It was designed to be a temporary solution while Health Information Exchange developed, but has ended up being a convoluted and often challenging solution to implement. Each provider needs what's called a direct address, which is essentially just a unique email address. A big problem with direct is that there is no central database for direct addressing, making it difficult to find the provider you're trying to send information to. Also, politics between the entities issuing direct addresses has made this solution even more difficult, with some systems not recognizing valid direct addresses, forcing some providers to have more than one address. Overall, direct can work to exchange information, but it's not a great option. On the flip side, we have Health Information Exchange, or HIE. HIE uses a third-party network to allow doctors, nurses, pharmacists, other healthcare providers, and patients to appropriately access and securely share a patient's vital medical information electronically, improving the speed, quality, safety, and cost of patient care. And in Michigan, our network of organizations that make up the state's HIE structure is governed by MIHIN, the Michigan Health Information Network. This next slide gives a visual representation of Health Information Exchange. Without HIE, the transfer of health information creates this complex matrix of communication between physicians, specialists, pharmacists, insurance companies, hospitals, and patients. There is tremendous overlap and duplication of effort, basically a highly inefficient system. Health Information Exchange looks to change all that by acting as a single reliable source of patient information. Routing and accessing patients' electronic health information through an HIE greatly improves the completeness of patients' records, which can have a big effect on care, as past history, current medications, and other information is jointly reviewed during visits. Appropriate, timely sharing of vital patient information can better inform decision-making at the point of care and allow providers to avoid readmissions, avoid medication errors, improve diagnoses, and decrease duplicate testing. Michigan's HIE structure is somewhat unique as well by this governing organization I already mentioned, MIHIN. MIHIN essentially acts as a network of networks, an overarching umbrella that links all of Michigan's various HIEs together, represented on this graphic as HIE QOs, or qualified organizations. This is a very busy graphic, but it shows MIHIN in the middle as the central gateway for all the various stakeholders in our healthcare landscape, with everyone feeding data to and accessing data from MIHIN. Likewise, MIHIN is the single point of access for the state of Michigan, with all the various state entities like Medicaid, syndromic surveillance, MICR, and the data warehouse all relying on MyHIN as the information pipeline. There are several HIEs around our state. Some HIEs are regional, and others, like Great Lakes Health Connect, have moved beyond a region and now cover the entire state of Michigan. Pricing and service offerings vary greatly between HIEs as well. Though this will certainly get better in time as HIE evolves further in our state, it's often best to use the HIE others in your area, especially the hospital, are using, as it makes the data exchange a bit smoother and more reliable. Best practice is to shop around and compare, but also talk with other healthcare providers in your community to see what they're doing and why. Connecting to an HIE to exchange electronic patient data provides a wealth of benefits, such as better patient information, lower costs and time to find, transmit, and use information, improved patient safety and outcomes, reduced unnecessary utilization, reduced hospital admissions and readmissions, and fewer duplicate tests. The topics just covered center on data collection. Now I'd like to turn things over to Dr. Makris, who will discuss ways you can now use that data to help you identify hypertension and diabetes.
Thanks, Bruce. Now that you have structured data, some from direct entry, some from health information exchange, you can use it for more than just documentation. It can be intelligently filtered and presented at appropriate times to enhance patient care. This is clinical decision support. A key here in the first bullet point is the phrase healthcare team. CDS is not limited to the physician, but can apply to extenders, medical assistants, and even the patient. When you think of CDS, pop-up alerts are often the first thing that comes to mind. Decision support exists in many other forms, some of which you see listed here, ranging from red text on an abnormal lab result to diagnostic support. Some can be set and will happen without any extra work on part of the provider, like red text on labs or medication interaction alerts when two incompatible medications are prescribed. Others require action on the part of the clinician or an administrator. For example, here you see lists of risk factors for hypertension and diabetes. CDS can be used to run reports on your active patient panel and identify those with modifiable risk factors who might best benefit from prevention. Targeted communication to your obese patients can provide them with treatment information, invitation to group visits, and referral to a dietitian or weight loss center. At the visit, decision support can be implemented to provide information on smoking cessation options, community exercise programs, or DASH diet instructions for your hypertensive patients. As useful as CDS can be, it's important to remember some pitfalls. Inundating the user with pop-up alerts will result in the information being ignored. Also, providing otherwise useful information at the wrong time or in the wrong setting can break down a clinician's trust and have a similar effect. Pop-ups can still be effective in certain circumstances, but it has to be urgent and clinically significant. As we've just shown, a tool is only as good as how it's used. This begins with the sound implementation strategy, starting with conversations with key stakeholders. This is not limited to administration or physicians, but can and should include other key roles who will be most affected by it, such as nursing, office managers, medical assistants, and IT staff. The specific problem needs to be defined, and then a decision made to determine if CDS is appropriate, and if so, what type. Cultural readiness should also be taken into account. Assess buy-in and motivation. Practical considerations need to be made. For example, if you're still implementing your EHR, you're probably not ready to shake things up. Then assemble a team, likely including some or all of these stakeholders, clinical champions, and outside help as needed, such as a vendor representative. Once you have your team assembled, you can get to the meat of development. Here you'll decide what the clinical goals are and how success is to be measured. You will also decide what guidelines to use, such as Million Hearts, American Association of Clinical Endocrinologists, or American Diabetic Association guidelines, or JNC 7 or 8. Office workflow should be assessed and streamlined if appropriate. Hardware readiness might be a part of this. Software evaluation is important too. Your EHR's capabilities need to be fully explored. Your vendor representative may know of similar efforts at other institutions, and there may be logic or templates already designed that fit what you're trying to do. Once ready to deploy, consider testing your CDS at a pilot site and make any adjustments before rolling it out to the rest of your institution. After a predetermined length of institutional use, you'll want to study the results and act on them as appropriate. That is a process we'll cover in more detail in a subsequent presentation. Here are some vendor-specific examples of current CDS. Epic uses templates called Smart Forms and Smart Text to guide completion of discrete data fields in standardized care. NextGen has disease-based or health maintenance protocols. Cerner has interdisciplinary plans of care, and their ambulatory product has registry-like work lists that will show you, for example, every patient with diabetes and an A1C greater than 8 who hasn't been seen in 6 months. In a real-world example of CDS, providers at the Cornell Scott Hill Health Center in New Haven, Connecticut conducted this experiment. We know patients with depression have higher rates of diabetes. This modest study of 8 behavioral health providers randomized 128 patients to a CDS or non-CDS arm. It showed that using a CDS reminder to screen for diabetes in patients diagnosed with depression was successful in increasing rates of diabetic screening. This is particularly important because the psychiatry visit may be these patients' only contact with a healthcare provider, and once screened, can be plugged into appropriate diabetic care. This example of decision support in pediatric hypertension used CDS in conjunction with training on proper blood pressure management techniques and was initially presented at the National AAP conference in 2009. The training, coupled with the CDS algorithm that automatically accounted for patient age and height percentile, resulted in improved identification of hypertensive patients by 25%. Earlier on, we showed some statistics on hypertension and diabetes. Although most, if not all, clinicians can tell you what a patient's blood pressure should be, patients are often uncontrolled or undiagnosed. Too often, a high reading is passed off as an outlier due to a patient running late, not being relaxed, or any number of excuses I've heard both patients and providers use. String several such visits together and you end up with a patient who is uncontrolled over time and therefore at risk. Identifying those patients is extremely important. Here are 2 simple examples of how Health IT can help you identify previously undiagnosed patients with hypertension and diabetes at your institution. This first slide shows our hypertension algorithm. It is provided for you in the toolkit. We'll take a closer look at the diabetes algorithm. Here's the diabetes identification tool. Starting with your entire patient population, you first identify your active patients. We've chosen 3 years here, but you can use whatever time frame works at your institution. If the patients haven't been seen in 3 years, you can reach out and remind them to reestablish care. Once established as active, you can use ICD-9 or 10 codes and the medication list to eliminate those already diagnosed with diabetes. If diagnosed with diabetes, you can proceed to the diabetes management tool. A link to the AACE guide on management of diabetes is provided in the toolkit. You can then apply the screening algorithm to the remaining patients, and if they meet criteria, they can be invited to come in for confirmation and initial diabetic care. For those not diagnosed with diabetes, you can go a step further and filter for existing pre-diabetic conditions. If a diagnosis of impaired fasting glucose or impaired glucose tolerance has already been made, you can proceed to the prevention tool. If no at-risk diagnosis exists, you can apply the pre-diabetes screening algorithm, and if positive, you can take more aggressive preventative steps. If negative, you can continue routine care. A study using methods similar to this identified 63,000 potential undiagnosed cases of diabetes across 9,000 clinics in the United States. I'll now turn it back over to Bruce for some closing remarks.
Thank you, Greg. As you've just heard, there are many ways that Health IT can be leveraged to identify and improve the health of your patients. Making the most of your technology means improving the identification of patients, improving the quality and convenience of patient care, improving the accuracy and diagnoses, and most importantly, health outcomes, improving care coordination, maximizing team effectiveness, and increasing practice efficiencies and cost savings. In short, healthcare teams should be leveraging the many aspects of health information technology to manage their hypertensive and diabetic patients. Failing to capitalize on the many ways health IT can be utilized means not maximizing your return on investment. Healthcare teams owe it to their patients to ensure they're making the most of the available technology to improve outcomes. With that, we'd like to thank you for your time today. If you have any questions regarding the material we just covered or anything related to health IT, please contact us at one of the numbers or email addresses on this slide. While we give attendees time to submit questions, we'd like to take a minute to briefly explain the upcoming webinars in this series and to encourage you to sign up if you haven't already. Today was the second part of a 4-part educational series. The first installment was a high-level overview of the many ways health IT can be leveraged to identify, engage, monitor, analyze, and improve the health of your hypertensive and diabetic patients. Today's session was the first of 3 deeper dives into the material covered in that first presentation. Additional sessions take a more in-depth look into using health IT to engage and monitor your patients, followed by a presentation on analyzing the data and using it to make important practice changes. As mentioned, we've also developed a set of tools to accompany these topics and strategies, tools you can use to help you leverage health IT to improve outcomes. These tools are available on our website at www.amceta.org, and all of today's attendees will receive an email with these tools. Once again, thank you for your time today. We hope to see you again very soon.